So remission means that you do all the tests, you examine the patient, there's no evidence of disease. So it doesn't say you're cured. It just says right now there's no cancer. So he went into complete remission and did great and felt great and actually traveled to the United States and saw his loved ones. And then about 6 months later, the cancer reappeared in his adrenal gland. So the adrenal gland is a gland next to the kidney,
above the kidneys,
and it produces hormones, so we need those hormones to live. And when the cancer reappeared, he had a biopsy in the adrenal. The biopsy was with a CAT scan, stuck a needle in the adrenal, took out some cells, and confirmed that it was cancer in one spot. And
metastases from the lung.
Yes, sir.
Okay.
So it came back from the lung. So to go from the lung to the adrenal means it went through the bloodstream.
Yeah.
And he started chemotherapy, and the chemotherapy failed to work. Actually, the cancer progressed. He had a new PET scan, and the PET scan showed the cancer had progressed. And so we're going to talk after this commercial break what happened to this gentleman, but right now we're going to break and hear from our sponsor.
All right.
For new or recurrent cancers, Radiosurgery New York specializes in new, non-invasive outpatient cancer treatment choices. First in America, first in New York, first for you. Radiosurgery Cancer Treatment. Decades of experience with primary and metastatic, large or small cancers. Cancer treatment from head to toe, acoustic neuroma to prostate cancer. We hit the cancer with no cutting, no bleeding. Hi, I'm Dr. Gil Lederman. We're the cancer treatment radiosurgery pioneers, with possibly a second cancer treatment choice for you, even if chemo, radiation, or surgery didn't work. Most insurances, Medicare, Medicaid accepted. Hyperthermia too. Tune in our new WOR radio program Sunday mornings 6 to 7 a.m. and Sunday evenings 9 to 10 p.m. To hit the cancer, call me at 212-CHOICES. 212 Choices. Super convenient, 38th and Broadway in Manhattan. Call me at 212 Choices. That's 212 Choices to hit the cancer.
Welcome back to the Radiosurgery Hour. This is Rob Redstone here with Dr. Gil Lederman at the WOR Studios in the heart of New York City. We're just a few steps from the Radiosurgery New York Cancer Treatment Center on Broadway and 38th Street. Dr. Lederman, the leading cancer expert, treats prostate cancer non-invasively. He was the first in New York with fractionated brain radiosurgery, and he's the first in America and in the Western Hemisphere with body radiosurgery. You can also call Dr. Lederman at 212 Choices for a free informative booklet and DVD. Hey, Dr. Lederman, we're back.
Hi, Dayush. How are you?
All right. How are you?
Fine, thanks. So we were speaking about this gentleman, 65, lung cancer, went in remission, and then the cancer unfortunately came back to the adrenal gland, started chemotherapy. The chemo did not work, and the cancer progressed, was diagnosed and evaluated with a PET CT scan. Can you describe what a PET CT scan is?
I'm not sure how it differs from a CT scan, but you can see things more clearly, right?
Right. So a PET CT scan is a CT scan which has those slices through the body.
Right.
But it includes an injection of radioactive sugar. And cancer cells often will pick up the radioactive sugar because they're growing more rapidly than other cells, most other cells in the body.
So you also get a measurement of how quickly they're eating up the sugar.
Right. How much they're eating the sugar. So you're seeing the CAT scan. So if you have a nodule, let's say in the lung or the adrenal, you can measure that by CAT scan, which measures shadows. But you can also get a measurement of how much of that sugar it's eating up. And then you can compare it from time to time to see if the cancer is getting worse or better. And also you can see new spots if, unfortunately, there are new spots. So it's commonly used. We use it often in evaluating patients. So this gentleman had a new PET scan. It showed that the cancer had progressed. And at that time, he saw his doctors elsewhere and also contacted me back. He's located 6,000 miles from us. He was offered to have standard radiation, about 4 weeks of standard treatments close to home. Because the adrenal gland is next to the kidney, that standard radiation would destroy the kidney. So it's kind of older style medicine where you couldn't direct the beam where you wanted to very well.
And that's the difference with radiosurgery, right?
Right. So I thought in this day and age, why not just treat the cancer, pinpoint the cancer in the adrenal gland, which we've done many, many times, hundreds, maybe even 1,000 times, and have a high success rate. There's fewer treatments, it's more accurate, and it'll protect the kidney. And I spoke with him and his family about it, and he felt just because he was not able to easily travel, he's older and a little weaker because of the chemo wore him down, even though 6 months ago he was here having fun in New York. Now because of the chemo it wore him down, and because the chemo wore him down and the chemo didn't work, he's going to end up taking a treatment that is less good than what we would recommend.
What a shame.
It's really sad
that
he's going to lose the kidney. The treatment is less likely to work because it's using little doses of radiation every day rather than a bigger few doses just aimed at the kidney. So it's a little bit upsetting to know that you can have better treatment, but then you don't necessarily have the chance to give the patient the better treatment.
Yeah, what are the chances of the cancer going from one adrenal gland to the other now?
Well, it doesn't usually go from one to the other. The cancer's in the bloodstream, so if it starts in the lung, if that treatment is not successful, the cancer can get in the bloodstream and spread from one place to another. But it's not from the adrenal to the other adrenal, it's from the primary site to wherever it's traveling.
Yeah, I was just thinking if he loses one kidney now, it'd be a shame.
Well, hopefully he'll change his mind before he finishes those treatments there.
Yeah.
There's also other cancer news. There's a shortage of chemotherapy in America. And
no kidding.
And many people are not able to get the chemotherapy that they had intended to get or is best for their cancer. And there's actually a survey about that looked at 243 pharmacists and doctors, and they asked them about how they were being affected by the shortage of chemotherapy. We're seeing it in our practice, people that come in and they can't get the chemo that they want. In radiation, we actually make the radiation. So if you think about our facility, we make it, we direct it where we want to direct it, and it's kind of like a factory and a delivery system and a
all in one
cancer center all in one.
Yeah.
Where for chemo, it's totally different. Different companies make different chemos and distribute it and sell it. And then those people that use it, the pharmacists or the doctors, have to get their hands on it. And
you got to order it and
deliver it. So maybe there's more steps. But in this study, 98% of pharmacists said that they had experienced drug shortages. And 93% said there was delay in giving chemotherapy because of the shortages.
Wow.
So it's impacting people in America.
What a mess.
Yeah, it is a little bit of a mess. And of those people, the number one shortages were in ovarian cancer treatments, colorectal cancer treatments, breast cancer treatment, and leukemia treatments. And some of the most difficult drugs to get were liposomal doxorubicin, fluorouracil, leucovorin, Taxol, and 34% of people reported spending more than 1,000 hours trying to remedy this problem.
1,000 hours?
Right. So you're talking about huge manpower to try to remedy the shortage. Some people would go to the gray market, which is maybe not American drugs, and there's been some issues with non-American drugs.
What's that? Is that Canada, the gray market?
Well, anywhere outside the recognized usual distribution centers. So
those drugs you were reading, which I can't pronounce most of, they corresponded to the diseases you said before, right?
Right.
Okay.
Right. So, but there's more than just those drugs. And we've had patients that we've seen that, luckily, many of them we were able to give radiation to and continue the radiation.
At least
part
they're
of the
getting
treatment.
some sort of treatment like that.
Right. So it's really important to continue treatment.
Yeah.
But it's something to think about when you choose what you're going to have, if you can actually have access to it. In America, we often don't think very much of access to drugs like that.
Yeah, because we usually get whatever it is that we
Get
need.
whatever we want.
Exactly.
So we've talked about some negative stories. There's also some positive stories that are out there.
Good.
Really, and breast cancer is one of the positive stories we have for today. A new study that was just announced at ASCO. ASCO is the American Society of Clinical Oncology. It's a group of doctors who give chemotherapy, and they just did a study on tamoxifen. Tamoxifen is a hormone that's commonly used to treat breast cancer. Breast cancers probably grow in the breast somewhat for estrogen or hormonal reasons, and tamoxifen takes away those or diminishes the growth from hormonal reasons.
Oh, all right.
So tamoxifen's been around for decades.
Yeah, I've heard of it before. Yeah.
So when I was in medical school 35 years ago, we used tamoxifen for breast cancer. And over the years, a 5-year course of tamoxifen has been pretty standard for women who have surgery and then are given tamoxifen to decrease the chance of the cancer coming back.
So they already had surgery to get rid of the cancer, and then the tamoxifen is sort of like another precaution or something?
Right, so an adjunct treatment. So it's an additional treatment after the primary treatment. The primary treatment would be either removing the lump of cancer or in certain women doing a mastectomy, and then maybe radiation to the breast area, and then afterwards what to do to try to reduce the risk of the cancer coming back. Right. So 5 years has been the recommended number, and when I trained in Boston, 5 years was it. If you asked, should I take 2 years or 10 years, everyone said 5 years is it. Well, there's an interesting study now that comes out looking at 5 years versus 10 years of tamoxifen. And this is women with early-stage breast cancer, and they were randomly allocated to 5 versus 10 years of tamoxifen.
Mm-hmm.
And guess what the results showed?
I don't know, 10 years is better than 5?
Yeah.
Oh, there you go.
Yeah, you're pretty smart. So there's a 15% reduction in breast cancer if you took 10 years versus 5 years of tamoxifen. So for the listeners out there who are on tamoxifen or loved ones on tamoxifen, you may want to speak to your doctor and ask about extending the treatment time from 5 to 10 years. And again, there was a 25% reduction in breast cancer mortality, and there were almost 7,000 women, 6,900 women who were in the study. So it was a big study.
Huge.
It was a huge study. And they also looked at other studies, pooled data, which meant multiple studies put together. And there was a 9% reduction in death rate in women who had 10 years versus 5 years of tamoxifen. What's the adverse effects? Well, some didn't tolerate tamoxifen very well. There was a slight increase in endometrial cancer, which is known. Endometrial cancer can be stimulated by tamoxifen, usually because endometrial cancer's first signs are bleeding. Women know about something abnormal in their uterus and go to the gynecologist and can be diagnosed. The risk of endometrial cancer was 0.5%. And
all right, so that's kind of low risk then, no?
It's very low risk, and those women usually are successfully treated. And you're talking about a big reduction in breast cancer recurrence and death.
Yeah, then that makes it worth it, because if the risk of endometrial cancer was higher, I'd say, well, then what's the point of taking this to not get that cancer if it's going to give you another one, right?
Right.
Yeah.
So we know that 5 years of tamoxifen reduces mortality by 34%. So it has a big role in reduction of breast cancer.
Tamoxifen.
And if you go on to 10 years of tamoxifen, it even has a greater chance of reducing recurrence and death rate. So again, it's something for someone to think about. That's a big positive step. And probably, since breast cancer affects several 100,000 women a year in America, probably many of those close to us will talk about that study one day and at least you can understand